introduce Mike again for those who aren't aware of him. Mike Stewart, physiotherapist, Payne educator, travels worldwide. Both Craig and I have been on his course. He's, as I said, he's solely responsible for my interest in pain and the way it's risen and been fairly intense over the last 3 years. And the reason we've asked him on is that we know pain, the undeniable fact is that pain is complex. It needs to be kept as simple and as applicable as possible. And Craig and I are both of the opinion that Mike does that beautifully. So within podiatry, and as you know, Mike, the main audience here are going to be podiatrists. That's not to say that there aren't some people with a good understanding, but on the whole, we're very mechanically minded. We're very biased in the mechanical way. That's the way we're taught, and we don't really get to touch on the psychosocial model of healthcare in our undergrad training. And we now know that that's probably something we really need to be concentrating and focusing on. So we really appreciate you coming on to educate all of us, myself and Craig included, of course, on this sort of really complex area.
Yeah, thanks very much. And thanks for having me. Hi to everybody who's watching. Pain is extremely complex, but as it turns out, not as complex as online live chats. It's more complex.
Yeah.
So no, pain is, I've always been fascinated by pain. I qualified as a physio 20 years ago, and it's weird to me how when I first qualified, I was constantly told that I had to treat Mrs. Jones where it hurts, that the pain was coming from her knee or her ankle or her back, and I would do things to Mrs. Jones, and Mrs. Jones would feel great for 2 days, and then she'd be back again wanting more of the same. So I became very disillusioned as a healthcare professional because I entered into healthcare to help people, but I quite quickly felt that I was part of people's problem rather than part of their solution. And I can see a couple of nodding heads. I'm sure some other people around the world are nodding theirs too. So one of the things I often see when I teach around the world, whatever the healthcare profession I'm teaching, podiatrists included, often one of the wishes that people have is to move away from being the person in power to empowering other people, to enabling other people to make sense of this weird thing that is pain, and not having to keep coming back for care and treatment. Awesome. So self-efficacy and resilience and all of those things which are essential.
So, I mean, the way we'd hoped it went, and obviously Craig, dive in any point, but we've been sort of pooling some questions and some comments over the week since we announced you were coming on, and really just to start really basically and talk about a sort of a definition of pain, and particularly how that definition of pain may have changed over the years, and then tease out some of those individual aspects of pain, and then ultimately towards the end, of course, talk about how this matters in clinic, how we apply this when we see our patients. Is that your dog, Craig, or yours, Mike?
Oh, sorry, Mike, before you start, I apologise, my dogs are barking in the background. Just before Mike answers that, Ian just alluded to the changing definition of pain. Let me just try something. Let me just share my screen, and hopefully it works. Can you see the slide, guys?
I can, yep.
Yeah, just, I think for me, the whole, following on from what Ian said, the whole pain thing is something that I've ignored myself. I've certainly been conscious that a lot's been happening because I keep seeing all these courses advertised, and so on Ian's recommendation, I did Mike's course when he was down here in Melbourne, and I did sort of wonder what I was doing there at the start, but in the first few minutes Mike put this slide up and it sort of hit me, this is why I'm here, and it's this changing definition of or understanding of pain from, well, these two definitions from 1980 to 2003. So I wonder if you start there, Mike, in answering Ian's question about that changing definition.
Sure. And it was really nice when you said earlier to Craig about the fact that, this made you realise why you're there. Because I think sometimes the neuroscientist Steven Pinker talks about this thing called the curse of knowledge, where you know it and therefore you assume other people also know it. And we do this all the time with a whole variety of different topics. But I always, part of me, when I first saw this as a student, these two definitions, the first thing I thought was pain has come a very, very long way in a very short space of time. This change from being something like Mountcastle says, which is to do with injury, and soma, purely to do with the muscles and the bones and the tissues, and not to do with the human being. So it's almost like you're a motor car rather than a human being. It goes back to what I was saying before about my disillusionment with being a healthcare professional, not feeling like I was able to truly help people by just pushing on bits that were hurting or doing interventional things to the part of their body that was uncomfortable. So I think those two definitions do show that huge change. Lorimer Moseley's definition in 2003, which I think is excellent, pain is an output. If we're going to pick up on any of those words that are interesting, first of all, a multiple system. There is not a holy grail magic off switch. There's not just one place that we need to work on to make pain go away. It's far more complex than that. Pain is an output. It's not an input. It's not coming from the part that hurts. It involves the tissues. Pain is a conversation between the tissues and the nervous system. But it's not, I always use the idea that Frank Sinatra once said, you can't have one without the other. So there's got to be some bottom-up information, and there's got to be some top-down information also. And I think the most important thing that Moseley alludes to is the perceived threat. This is what this saber-toothed tiger is all about. If you don't understand pain as a perceived threat, it's impossible to accept and acknowledge how easy it is to threaten people. We threaten people all day, every day, without meaning to. I'm never a finger pointer. I hate, saying you're wrong and this is wrong and that's right. But the problem often as a healthcare professional, if we don't understand the perceived threat that's intrinsic within pain, we threaten people. We threaten people with our mouth. This is a threat machine, the words we use, the posters we put up on our walls. So making sense of pain really does change your outlook on practice. Would you say? Would you agree?
Completely. Absolutely. The more it's fundamentally changed. We'll come on to this later, but it's fundamentally changed the way I talk to people and take a history fundamentally, which we'll talk about a bit later on, I'm sure. But I can't think of anything else I've learnt in the last decade that has so strongly changed the way I communicate. And I'm not saying I get it right all the time. I'm certain I don't. I'm on a learning curve, and I'm at the bottom of it. But I think that's why it's sort of grabbed me and hasn't let go of me from an interest perspective.
I think one thing that always stuck with me that changed my understanding of how I communicate with patients, and making sense of pain was one of those big steps, was a quote by Eccleston and Crombez, who argued that pain is an ideal habitat for worry to flourish. And I think I often say to my patients that it takes one to know one. I think one of the reasons that I'm so engaged and passionate about helping people with pain is because when I was younger, I had epilepsy. It was not very well diagnosed. I used to have these uncontrollable fits. And actually a lot of the symptoms that came with that as a kid was sheer blind panic. And the uncertainty of and the unpredictability of living with a long-term condition. And I think I see lots of similarities in all long-term conditions. It's quite interesting that when people come onto the course, they often say, I don't work in musculoskeletal care. I don't work with people with back injuries and neck injuries. I work with, in respiratory care with people with asthma and COPD or Parkinson's or MS. And actually a lot of the way that we try to empower people through knowledge, through making sense of their distress and their situation, and it is a good thing. And I think that brings us on to something interesting. I often try to get across the point that maybe the problem here is the word pain. We have lots of connotations, lots of influences from our history, from our education as healthcare professionals with the word pain. We think of it as ouch, like being pinched. And actually, if you look at the complexity of pain, maybe a better word to reflect the complex nature of it is distress. Distress sort of covers a whole range of things. If I'm a physiotherapist trying to fix pain, then to fix pain, what do? I might use my hands, I might use machines, I'm going to do something interventional. If I ask the same question but change the word to distress, now all of a sudden I've got a very, very different skill set. And a lot of healthcare professionals are a bit like a rabbit caught in the headlights when we're faced with people in distress, because how do we solve those problems? And that's sometimes where the communication skills and the knowledge comes in.
Yeah, absolutely. Should we rifle through the sort of comments that came in what feels like a logical order, and then we can go off on a tangent if need be? Is that the best way to do it?
Sure, yeah.
Certainly, yeah.
Right,
Yeah.
Craig, are you okay keeping an eye on any comments coming in?
Yeah, I am. I'm also muting my microphone as much as possible because my dogs won't stop barking. But, let's push on from your end.
I think those dogs are in distress. Okay, so we go back to sort of the definitions and how they've changed. It's probably best to start there again, just to recap. Certainly, I recall being taught this sort of model of, and we're mainly talking about foot pain because we're a group of podiatrists, or at least distal peripheral pain, and we're talking about this concept of something hurts in response to something external. An external stimulus damages a tissue, and these pain receptors take the message to the brain, and we're just not going to be able to switch that off until we've healed, or until we've fixed something, whether it be mechanical or tissue damage or a combination of the two. And what we now know is that there's probably so many things in there that aren't particularly supported by the science of the day. I think that's reasonable to say. So we've moved on to this model of or this definition that pain is a very personal thing. Pain is a very contextual thing. It is an output, as we say. It's an output of the brain 100% of the time, with no exception, I believe, is what Laura Mosley mentioned. And we really just want to sort of then talk about some of the things around that, some of the sort of discrepancies between the two, because definitely when I've tried to talk to people about this, it sort of feels like we're trying to tell patients that they're imagining pain. Pain's all in their head. It's all in your mind. And suddenly we're not the therapists that we used to be, or the biomechanists or the podiatrists, the physios. Suddenly there's this expectation, what do I need to be a psychologist, a psychiatrist, a counsellor? And that's not really the message, is it?
No. God, I think that brings up, again, the complexity of this problem is that there's so much to look at. First of all, a psychologist who I work with always says that, he sort of wishes that he was not a psychologist and he was a physiotherapist, because actually you can do things as somebody who's not a psychologist. If we have those skills, then we do psychology all day, every day, don't we? I'm sure in podiatry, you're constantly using psychology. We don't call it psychology. We maybe call it reassurance and empowerment and communication skills, but effectively what we're doing is dealing with people who are in distressing situations, who the research shows, lots of meta-analyses and systematic reviews show that what do people in pain want? They want to get their life back to normal. They want to be themselves again. So there's a huge amount of things to consider here. I think the first thing to say, and pain is extremely complicated, but it doesn't have to be really hard and really, really complex to try and help somebody make sense of it. That distinction between nociception, between, say somebody's standing on my toe, and the perception of the threat of that information coming in. One way to try and get it across to people is to provide an experience. The psychologist Fordyce once said, for behavioural change, if you want to help somebody change their behaviour or make sense of their experience, for behavioural change, information alone is like throwing spaghetti at a brick. So just talking to somebody to help them make sense of this weird pain thing is not enough. We have to use experiential learning, which requires maybe using an experience that we've all shared. So how I do that is I talk about hearing. I don't talk about pain with people. I'll help them make sense of how hearing is an input and it's an output as well. I mean, for me to hear now, I'm going to have to take information in through my ears, and then my brain interprets that information, bases it on the context. So if there's somebody running in the room with a machine gun now, the context will shift completely. All of a sudden, there's going to be this huge change. So hearing involves input, but the actual process of hearing something is the output. It's the interpretation from here. Hearing is always a perceptual brain construct. And in the same sense, if somebody stands on my toe, all that is an input. It's just like the sound waves coming into my ear. It's not pain. It's just an input of information, of warning data. Nociception is there was a simple trivialization, Patrick Wall said. We called it pain fibers. And nociception are not pain fibers. It's just encoding of noxious stimuli. And that's not pain. That's not a perceptual thing like hearing. It's just information, just like sound waves. And that sort of goes some way to maybe what help people is shifting to hearing or sight and different senses.
So a reasonable summary would be that pain is not generated in the foot and ankle complex. That's a fair thing to say. We receive a stimuli, some form of sort of input that then is taken to the brain as information. The brain then, with all of the information available and the context available, ultimately decides on the level of threat, real or perceived, and pain is the possible output of that. Is that a reasonable summary?
Very much so, yeah. I think a really good way to try and help people make sense of their pain is to show them how weird pain is. Prove it. I use lots of stories. I'm constantly on the lookout for weird pain stories because there are so many of them about. So I'll use one where there's a guy in Shanghai. It was in the Times newspaper here in the UK. A guy in Shanghai who was walking down the street and a knife dropped from 16 stories and landed in his head. And I showed him an image of this huge knife stuck in this guy's head on an X-ray. As a qualitative researcher, it's interesting because it's often the words that give things away. It wasn't the shocking thing of a knife in his head. It was his recollection of the experience. He said it felt like a teardrop, like a raindrop on his head. He didn't notice that there was a knife in there. He hadn't noticed any pain until the local tobacconist stopped him and said, "You've got a big knife in your head." Then pain came on. So pain is really weird. It's a conscious experience. It's based on perceived threat. That guy had no perception of perceived threat. He just thought it was a raindrop until the tobacconist said, "You've got a huge knife in your head." Pain washed over him. He dropped to the floor. Agony. So I quite like sharing weird pain stories because I tend to find that weird pain stories elicit weird pain stories from patients. I had a lady the other week who came in and said to me, based on that conversation we've just had about the guy in Shanghai, I've now remembered this weird experience I had where I, ran along the beach and smashed a glass bottle all over my foot, but didn't notice it until I got to the end of the race. She was so focused on something else, her perception had shifted. And I think that's an interesting thing to pick up on is we had a lady a while ago and she said the nicest thing about making sense of pain as a perception is that it was liberating for her. She'd spent years being told that her knees were shot to bits and that she was going to need surgery. And she said, I couldn't change my knees, but I could change my perception. Dyer once said, change the way you look at things and the things you look at change. It's a nice sort of change and a shift in your viewpoint. And that's what we have to do is help people reconceptualize pain in a meaningful way.
Brilliant. And let's just talk a bit more about we've touched on pain being a very personal and individual thing and being weird and complex. And also we've talked a bit about how dependent it is on context. So we touched on a few of the things there. So certainly from reading your work and others, we know that certain things that can feed into this are stress, anxiety, being sleep deprived, your beliefs, cult. I think there's a cultural difference from what I remember. What are some of the other things that we really need to be thinking about? And obviously previous experience and injury being them, because they're going to feed into our history taking, aren't they?
Yeah, well, I'm sure most people from their training probably remember Payne gate theory. Patrick Wall, Melzack and Wall from 1967. And Payne gate was this very simple idea of opening and closing a gate. And Melzack in 2005 came up with Payne neuromatrix theory, which sounds very complex and very Keanu Reeves-like maybe. But Payne neuromatrix theory is saying what you've just said, that actually there are lots of different parts of the brain that come together, like a boardroom meeting, lots of different people coming together to make a decision. And then pain is then the output, or sometimes the decision not to provide an output. For example, if you trip in the road and sprain your ankle, if it's really, inflamed and you've had some form of injury, if you're on a quiet road, the context is, oh my God, this is horrible, I've sprained my ankle. If you're on a busy city street with a big bus coming towards you, the likelihood is you're not going to get any pain, because which part of your body makes that decision to get out of the road? It's certainly not your ankle. It's the output. It's that sort of instantaneous survival mechanism to get out of the way of the bus. So, I think we have to help people make sense of pain as a perceived threat. I think that's one of the most important things to do, is to understand that pain is linked to threat, reduce the threat in our language and in our communication.
Great. And actually, Jay, I'm just looking at the comments that have come in. James Welsh has just mentioned about the literature on sleep. I think the relevance of sleep deprivation on someone's pain. I mean, there's pretty good data now to tell us if someone isn't getting enough sleep, if they're sleep deprived, that their I think the word sensitivity is appropriate, but correct me if I'm wrong, that they're much more sensitized. Is that the right word to use?
Yes, very much so. You're much more sensitized when you've lacked sleep for a consistent period of time. Also, if you think about it, we end up with a situation whereby our cognitive function is impaired, our ability to react to situations is impaired, our drive and our desire and our self-esteem, all of those things. And I think this comes back to, again, pain is, we call it the biopsychosocial model, but actually if we were to reflect the evidence, it would be the socio-psycho-bio model. The social impacts of pain are enormous. And if we think about all of the social impacts of not being able to sleep, that's huge. That's an enormous thing, not being able to work maybe, or do your job very well, or look after the kids. So I think one of the things that I often do when I'm teaching is to emphasize the importance on the social impact of pain, and become better at helping people live a life that's important to them, that has value, and going back to those things that they hold dear.
Yep, great. Another comment that came in from another podiatry colleague, Dr. Kevin Kirby, was off the back of a discussion I was having with him several weeks back about pain. And I rightly or wrongly, and please do call me on it if it's wrongly, but I used a sort of throwaway comment that about, I was trying to get across that pain was an output. At least that was my understanding of it. So I referred to pain being an opinion of the brain. So it takes all the available information, the danger, the threat, the context, the experience, etc., and it makes a decision. It forms an opinion on whether pain as an output is an appropriate response. And Kevin took sort of took exception, so to speak, to my use of the word opinion. So I thought might get your take on, is that an inappropriate word to use, and if so, what's a better word?
Yeah, I think opinion. The word opinion was first used by Patrick Wall many years ago. Patrick Wall said that ongoing pain is less about damage to the tissues and more about the brain's opinion of the body part. Which essentially, I suppose, a better way to look at it would be, imagine that the body is like a large company. And if the body was a large company with lots of different departments, your ankle might be the admin department, the back might be the sort of human resources department. But the part of the body that's making all the decisions, where the output is coming from, is the brain. That's the CEO. So I always get across this concept that, if 10 years ago, before you had your foot pain, say, you were running regularly, you were going to work, you were doing things, your brain's opinion, your boss's opinion of that body part is good. It's performing well. It's hitting its targets. It's doing okay. If over the last 10 years, you've started to have more pain, and that means that your sensitivity level has gone up and your ability to do things has dropped. So we end up with this mismatch between how sensitive you are and how good you are functioning as a human being, then there are problems. The opinion, the view, if you like, the scrutiny on that department then increases. We know that we have an increased amount of observations from the nervous system, in a sense, of what is this area doing? How do I get it back to performing well again? And that switches on all sorts of other parts of the brain, the amygdala, the limbic system, which then starts to seek out threat. I sometimes get across this idea that pain is like a music gig where the devil plays all the best tunes. So if your ankle starts to become uncomfortable, the boss starts looking, and then all of a sudden those parts of the brain that are the affective mind, the amygdala, the limbic system, start to look for threat information, start to seek information that supports your belief. Yeah.
And probably a good time, I think, to come on to acute versus chronic pain. Because you touched on a couple of things there. The first was that and I read this in your paper in the BJSM, which is a beautiful sentence that suggested that the duration of pain is key when we take a history, because ultimately the longer that pain has been going on, particularly if it doesn't match with the biological time frame that you'd expect healing to occur within, the far more likely that we are not dealing with a scenario that involves just tissue damage anymore. And as podiatrists, certainly not exclusively, but the lion's share of our musculoskeletal work is often people that have been in pain for several months. It's usually the way they present. So I think it's key, if we're going to educate people, and we know that educating on pain is key, we need to understand it ourselves. So viewing pain as this alarm system, that can go wrong and can be faulty like any alarm system. Could you just outline and sort of simplify acute pain versus chronic pain, and how we could perhaps discuss this with our patients?
Yeah, I think again, rather than providing people with information, and when you sort of talk to people, they just sometimes glaze over a little bit. So
All the time.
Yeah. I do this as an educator. It's got to be a dialogue, it's got to be a conversation, and that conversation has to be based on more than just information. It has to be based on experience. So I do this with patients quite often. If I cut my finger, if I'm chopping vegetables up and I cut my finger open, how long does it take for that cut finger to heal? And most people will say, well, it depends on the cut, but within days or weeks. And the truth of the matter is that, of course, you don't have ongoing tissue harm that lasts for 10 years, 20 years, 30 years, like you might have with pain. So what is the point of pain? Why would it hurt if you cut your finger? Most people will say, it's warning me. It's warning me. It's telling me to pull the knife away, which is sometimes why we get lots of patients who will say, I don't like taking pain medications because they're going to mask my pain. I want to feel it. So pain for most people is a useful thing. One of my patients once, you know your patient has got it when they're able to say it in their own words. And she interpreted it as, let me get it right. She said, pain is my friend at first. If I cut my finger, it's useful. But if it's been dragging on for a long time, it's like that friend that refuses to go home from my party. 3 a.m. looking for, Jack Daniels, that sort of thing. Deborah Padfield, the pain researcher, she once said something, and I thought it was quite interesting. She said that pain is the gift that nobody wants. It's really important. If you're somebody who lives with a condition called congenital insensitivity to pain, you're incapable of feeling pain. I show images of these people to my patients who themselves are living with lots of pain. And they often say, what a blessing. Imagine living a life where you can't feel pain, where it's impossible. That's not a blessing. We need pain. Pain is a crucial part of being a human being. It tells you if something's wrong. But the problem is, of course, that injury that you've sustained, at the start of the onset gets better. But the problem then is for millions and millions of people across the planet, and pain is an epidemic that keeps growing every year, despite the fact that your tissues have healed, your pain gets worse and worse. And we then continue to have more problems where we involve your beliefs and your attributions, and failed attempts with healthcare professionals where they've tried to do things interventionally to the bit that hurts, and it gets better for a bit. We scratch the itch and then it returns. So people end up going around this loop where they try to seek the off switch, they get short-term help, the pain comes back again, they worry even more, and all of a sudden that loop starts to cost a lot of money, and it involves a lot of distress and a lot of problems for millions of people.
Yeah, absolutely. So clinically, when we got someone sitting in front of us in clinic, we know, from what we've talked about so far, when we're taking a history, we need to ask, rather than just about, tell me how you did, tell me how you, thinking mechanistically, what were you doing when you injured it? And we still, of course, do ask that, but we need to be broader that, when someone presents with a longer duration of pain, we need to broaden everything. That's certainly my take home from your paper. We need to ask about beliefs, concerns, previous injury. We've always asked, what are your previous injuries? And we're often thinking mechanistically, once you've sprained your ankle once, you're more likely to sprain it again, or once you've injured one area, perhaps it's more vulnerable, it wasn't rehabbed appropriately. But it's reasonable, I think, to say, once someone's had one injury, when they start feeling sensitivity in that area again, the way they respond, the way their brain and the output from their brain may be completely discontinuous with what's actually going on.
Yeah, very much so. I mean, I think one of the things that I do, and it's quite a simple, practical thing, but I've learned over the years before my first patient comes in, before I meet them for the first time, I ask them to come up with a list of things, a list of questions, a list of problems, things that they're experiencing. So that list, 99.9% of the time, that list is never, well, I have pain here and it just hurts and it's 7 out of 10. It's never as we were trained. That list often involves other things, such as, I'm not able to work, I'm having this problem here. So I think asking people to come up with a problem list will really highlight the complex social, psychological, cultural issues. I think that another point as well, you touched on culture before. I'd like to share a story with you from a course I taught in Paris a while ago, where there was a Brazilian guy, a physio, who was on the course. And he said what was strange when he first moved to Paris from Brazil is that he suddenly noticed that all these Parisians would be talking about, my pain is sharp, my pain is throbbing. They'd use these sort of words of mechanistic harm, the stuff that we've learned from the McGill Pain Questionnaire, lanciating, sharp, stabbing, burning, throbbing, all those things. And he said back home in the Amazon, he's from the far north, Manaus in Brazil, he said, when I work with the tribes people, they'd never talk about their pain. They'd just come in and say, when I'm out chopping wood, I can't do this, I can't get my shoulder all the way back. Or they talk about function. They wouldn't talk about pain. And the historian Joanna Bork says that in the Western world, we used to do something very similar. There was this shift that came along, maybe we think it was in the 18th, 19th century, where we started to focus a lot more on describing pain and talking about pain and focusing on the problem rather than focusing on the solution. And I always get across to people that the problem isn't the problem, the solution is the problem. It's great, okay, let's help you make sense of pain, but let's now move beyond it. Let's look at what are the solutions? How do we get you back to doing these things again?
Because we're certainly taught and still, difficult doctrine to get away from it. Tell me how your pain feels. Does it feel sharp or does it feel dull? And where is it on? Well, let's come on to the VAS, the visual analog scale, the 0 to 10, 0 no pain, 10 the worst pain you can imagine. Certainly, as you know, my 4 out of 10 may be your 7 out of 10. And I know I've read authors that are no fan of the VAS for that reason. I mean, in your opinion, where do we stand with using, say, the VAS? Should we not? And also, what sort of questions do you think we should be asking to elicit these responses? How should we be getting this information from the patient?
Yeah, I think that the first thing to say about VAS is once you start to make sense of pain as a perception, you start to see the issue. There's a problem. There's a big dilemma with the VAS scale, which is, of course, we're saying the word pain. And we know that if we put people in an fMRI scanner and we say the word pain into a microphone, on comes the experience of pain, the neurological output, if you like, in an fMRI scanner. So it's a bit like saying, do you have a thumb? So those of you who are watching at the moment, if I ask you if you have thumbs, of course you'll go, yeah, I've got a thumb. And then if I get you to hold your thumb up and think about your thumb and look at your thumb and concentrate on how it feels, most people start to feel something in there. They'll start to get a sense of, pins and needles, or it gets heavy, or they want to click it. And what's interesting is you weren't aware of your thumb until I said the word thumb. And this is a problem with pain, is that the more we say to people 0 to 10, what's your pain like, all we're doing is we're switching them on. We're cognitively shifting their focus, their attentional bias towards pain, towards the perception of pain. And I think maybe we have to shift away from pain, saying pain less, and starting to focus more on, if you watched me in practice, I focus much more on like the Brazilian guy was saying, how confident are you to try this? How happy are you when you're doing this? So that the attentional focus shifts massively towards doing things, getting you back to lifting your kids and, whatever's important to you in your life, going back to work lifting boxes, rather than keeping that focus, that sort of very blinkered focus on 0 to 10, how's your pain? There was a patient once in a study, Deborah Padfield study, and she said, my pain is evil. Where do I put evil on a scale of 0 to 10? And again, that sort of highlights the problem is how do you put pain on a numerical scale, or how do you put it into words, actually? Words can be very hard to describe pain. So this is where sometimes we get into the realm of metaphor. It can be a more creative way for you to express the experience. But yeah, I think VAS, it has its place, but I think is very much overused. And often from my experience, people often say, I have to use it because I'm told I need to use it. And it was part of my training. And actually I would, invite you to go and look at the literature and see the issues, some of the qualitative work, particularly, where we know that people don't like that question. 0 to 10 pain, what's it like? Yeah. Shift the focus away from that.
We'll link to some of the literature below. On that note, a story of my own, I asked a patient once, try and describe to me the sensation, and expecting sharp, dull, 7 out of 10. And they said to me, it feels like a Prodigy song. And I was like, I don't know what to do with this information. I wrote it in my notes, and I'm just desperate for someone else to read that one day and go, what the hell is this going on about? But again, really just hit home to me how personal it was to them. And that was just the best way they could articulate and verbalize the way it felt.
Well, do you know, it's not that silly a point, really, in a sense. I mean, part of the work I want to do for a PhD is looking at, I do lots of work with metaphor. And I for a long time now, I've been asking patients, if your pain was a song, which song would it be?
Oh, really?
rather than talking about 0 to 10, I want to try and understand the experience that they're having. And Bolton, who's an educator, talks about the need in healthcare for serious playfulness. So there's a need for you to try and be creative and playful, to try and get information out of people, not just the standard dry, literal ways that we've been doing things for years. We know that they can not help many people. So, but it's not that weird a question, I think, to ask people what their pain would be, what their song would be. I ask lots of people on courses, if they have a song that relates to something in their life, an experience, a nice experience like a wedding, or maybe a first dance, or a bereavement experience. And virtually everybody has a song that they go to. And I've had lots of experiences with clinicians and patients where they learn a lot about the human being in front of them from the songs they choose, the lyrics they choose. It sort of allows them to open up to express something. So I'm far more into a narrative exploration of pain rather than a sort of tick boxology, as one of my patients said, that sort of, going through the motions and ticking through the boxes.
Yeah, absolutely. So let's talk a bit about communication, the words we use, words that can have, as you said, the absolute ability to harm as much as they can help. And I know from keeping an eye on the physiotherapy world, this is often discussed in the concept of back pain or the spine. That kind of jam donut squidging out the jam, which is just a horrific sort of nocibic image. And certainly some of the physios in clinics cutting out, that little spine model that has the red disc bulging. And I know I've seen physios that have taken, a knife to that to remove it from the clinic because it's so nocibic. I mean, I know you're not a podiatrist, but in the world of podiatry, can you think of any sort of terms that immediately you sort of think that would be a really, really poor choice of words? I mean, we're often looking at people mechanically, posturally. There's a term I've always hated, and it's, I don't know, Craig's no fan either, and we're not the only two, and this is the term overpronation.
Yeah.
We've never been fans of this term for numerous reasons, because, from a mechanical point of view, it's undefinable, it's poorly correlating with injury, blah, blah, blah. But let's think more in the context of what we're talking about here. Surely this term has the ability, because of the kind of reputation it has, to be harmful if we really think about it at that level.
Very much so, and especially in this connected world where if what I often do when I work with patients, I'll often say to them, what words have you heard? And they tell me about, scoliosis and inversion. There's one for podiatrists, inversion. And then they don't understand. And again, it comes back to this curse of knowledge that Steven Pinker talks about, that we understand these words. These words were new to us when we went to college, but now they're such a normal part of our language that we don't even think of them as an odd word, a new word, or we don't see the threat in that word. So I'll give you a couple of examples, one that's physio and one that's maybe more towards podiatry. I had a guy a while ago who came in to see me, and we were going through our sort of standard red flag questions for back pain. So any problems with your bladder or bowel, I said. And he suddenly sort of looked really quite concerned, and he said, "Do you think I have bowel cancer?" And we had to stop and have a chat. And essentially, just the fact that I've said the word bowel, for him, reconfirmed the fact that he thought that he had bowel cancer that killed his father the year before. And of course I didn't, but that's just one of the standard questions. But he was frank enough and open enough to be able to communicate that to me. So words that we utter have no meaningful threat to us, but they might have huge impact on people's perception, and it reconfirms, it rubber stamps their sort of credentials as somebody who's about to die or has this huge threat. Another one, which is maybe more interesting from a podiatry point of view. My wife has a son who's 24. He's just qualified as a paramedic. And over Christmas, on Boxing Day, he had his nephew was saying, "Oh, I've got this problem with my toe." So my stepson was looking at this kid's toe, and he was saying some of the language that he was using, as a young healthcare professional, was quite technical, quite jargony. Or, I think that toe has got some inflammation under there, and of course the little kid started crying his eyes out. And I said to him, this is the first lesson in nocebo. Nocebo, for those of you who don't know, I always find it quite interesting how patients always know and clinicians always know placebo. Yeah. Placebo is a real thing. It's the ability to reassure people. Louis Gifford once said, reassurance is a bloody good painkiller. Nocebo is placebo's evil twin. It's threat information. It's saying you have all this inflammation under there. We might need to take that nail off. You might need to see the doctor. And of course, what did we see in this small child was an experience of threat. So I think when you understand pain, you understand how it's very, very easy. We sit in a pivotal place where we can take people who have an acute injury and we can make them somebody who has an ongoing awareness of a problem that shouldn't really be there. We can disable people without meaning to.
That for me is the toughest thing. I think that since I've been reading more and more about this is how I reconcile it with my sort of mechanical approach to things, and also it's made me visit everything I say and almost made me sort of say, what can I say anymore? What's okay to say? And I think it's the more I read, the more I realize it's important. But at the same time, I can see why people think, I'm just going to carry on as I am, because it's pretty stressful re-looking at everything and you do on a daily basis.
Yeah. I think a psychologist that I used to work with always said to me that if you're talking more than your patient, there's something wrong. There's a problem. And I think that comes back to, I often get across this idea that the answers to people's problems, the solutions to people's problems lie in their words and thoughts often, not ours. And I did a study, it's due for publication later on this year, where we looked at physiotherapists prescribing exercises for patients. And what we were really looking at was the percentage amount of time that we could hear the patient's voice. 6% was the average. So 6% in a consultation. So often we know, a lot of the research shows that, exercise prescription and healthcare in general is very didactic. It's very clinician-centered. Patients often feel disempowered through the process. And I think the tip that I would give is what I've learned, I think, over the years is the more that you listen to people, the more they'll tell you stuff and the more they'll work out for themselves what the answer is. Our job is to guide rather than tell, and that can be a very hard shift.
Actually, Mike, when I did the course, I can remember one slide which you put up, which was a MRI of the spine and an old telephone beside it. And we're talking about the wiring, and then in other parts you were talking about some of the normal anomalies that have been found on MRI. We've just had a question come in which reminded me of that part of the course, and it was X-rays of a heel spur are a very threatening image for a patient. And it makes a lot of sense for them when they see it. But I can't remember the exact figure, but 20 to 30% of the normal population have heel spurs. So that's a really good example of what you were talking about in the context of some of the normal anomalies. So I just wanted to comment on that.
Yeah, I think we know there's been so much evidence now to show. We know a few things about imaging, particularly MRI. First of all, a very low yield of useful findings. Secondly, a very high yield of misleading findings. And thirdly, a lack of proven benefit for outcome. We know that if you've had an image done of your bone spur on your calcaneus or of your back, we know that having that image doesn't necessarily correlate to better clinical outcomes. So I think we have to be very, very careful when we're, first of all, describing images to people, and secondly, showing them. I had a lady a while ago who said to me, at the end of the process that we went through, she said, it's great. She said, I feel liberated. I've made sense of it. I understand it. I've moved on. I'm back playing tennis and doing things. She said, but if there's one thing that I would change, it would be never to have seen my scan, because the healthcare professional didn't ask. They just sort of said, they assumed that she would want to see the image of her back. And she said, it scared the living daylights out of her. And still now to this day, even though she's doing better, she still sees that at 3 a.m. in the morning. And there's a game in psychology. It's called the chicken game. Would you like to play the chicken game with me?
Go on, Craig.
The chicken game. The chicken game goes something like this. Your job is to now not think about a chicken. Game over. Game over. As soon as we say the word chicken, already the cat is out the bag. So we have to be very conscious of that sort of negative suggestion, the impact of things when we're showing people images. For example, something so simple as saying, don't worry. It's something that we all do to try and sort of reassure people. But of course, what's the first thing you do as soon as I say, don't worry? You worry. You start worrying. This goes back to classic psychology studies done in the 60s, putting a small child in a room and saying, don't eat the big juicy marshmallow. The kid wants to eat the big juicy marshmallow. So we can switch people onto things. And I think we have to be aware of that when we're talking about imagery and scans. Great.
I've got one question. I know we've been going on for a while, Craig, but this is one that has been asked of me a couple of times, and I'm just not smart enough to field it, if I'm honest. And it's been asked usually by podiatrists. As podiatrists, you probably know, we inject in and around the foot and the ankle quite a bit, local anaesthetic, corticosteroid, and things. And if we appreciate that pain is an output of the brain, so there are no pain receptors, distally, peripherally, and whether we experience pain or not is completely, as we say, the decision of the brain. A question that's been pointed at me is, well, how do we explain how local anaesthetic works? How can we inject a part of the foot and then feel no pain?
Well, a local anaesthetic will change the sensation, won't it? It will change the sensation in the area, so you won't feel it. It will essentially effectively numb the area. And by doing so, we'll reduce the nociceptive drive. So the nociceptive input, which is going north from the foot, up through the spinal column, up into the sort of higher centers in the brain, is now not so driven. It's not so active. So therefore, you're not picking up on the perception of threat. Also, you've got to think that it's never as simple. You can never really say with pain that it's just one thing. I always think, sometimes when people say, let's go back for a second to the idea of running across the road, spraining your ankle, not feeling any pain in that scenario if a bus is coming for you. If a bus is 50 meters away. Some people will say, oh, it's just adrenaline. That's just adrenaline. That's a bit like saying you can make a very complex gâteau with one egg. It's one ingredient in the bowl. So I think the other thing we have to consider when we're looking at anaesthesia is the context of the situation. Surgery is by and large in the Western world often seen as the sort of the magic button. It's if healthcare is seen as a battlefield, the likes of you and I are the sort of soldiers in the tanks, we're the early stage stuff. But surgery is often seen as, it's gone beyond fighter jets, they're the MRI scans. And now we're looking at the nuclear warheads. Surgical intervention is the sort of the top intervention that can be done that will kill the pain, win the war. I suspect that partly when we're looking at anaesthesia, we are also looking at some belief systems, some social systems, the fact that you're in with the top guy, the surgeon, or with the podiatrist who has the big needle and is able to cure the problem, fix the problem. So I think there's a whole range of things to consider, not just physiological, but also social and psychological, which is where this socio-psycho-bio model comes into play.
I mean, it's infinitely more complex and feels more woolly than just, I've put a chemical in the toe, it's blocked the signal going to the brain. And I think that's probably why people prefer the latter description. You think that's fair to say?
I would, yeah. I think, I've myself and other people like me who try to help people make sense of pain and help you to help your patients. We're doing a difficult job because effectively it's much, much easier to think simply. It's much easier to sort of just see the tissue and the muscle and the bone. And of course, that's part of it. Louis Gifford, and I loved what he used to do. Louis Gifford said that we have to have in parallel reasoning. You have to be, it's a bit like a set of train tracks. You can't just have one train track, which is the psychosocial impact of pain. You can't just be thinking about the human being, their beliefs, their attributions, without this train track, which is the biomedical stuff, looking at pathoanatomical conditions and all that stuff that we've learned over the years. We can't throw that all out the window. So pain definitely involves tissues. Pain definitely involves, us revisiting all of those things that we've been doing for years. It doesn't mean that we throw that out the window. In physiotherapy, we had this erroneous debate, which was hands-on or hands-off. If I'm not going to touch patients, and I think it's really bad, because if I had £1 for every time I see a patient who says, they didn't touch me, I've come to see you because the last guy didn't touch me, and how could they tell me about this sensitivity that I'm having when they didn't touch my back or my ankle or my... So if we're talking about communication, touch is communication. So I think you cannot take the bio out of the... I'm not going to say biopsychosocial, I'm going to say socio-psycho-bio, because I think a far more accurate reflection of the evidence.
Great. Well, Craig, have you got anything else that you want to say?
Or should we wrap up? I think
we probably just need to talk about Mike's course, because like I say, it's completely responsible for my interest in pain over the last 3 years, my continuing interest in pain. As I say, I'm no expert by a long, long way. And I've encouraged every podiatrist I've spoken to since to go on it if they get the chance. And I know you have, and I know that Ian Linane has, and probably some other guys. So it'd be great. I think we give Mike's course a plug. I can see you've put it up on the screen now, actually.
Thanks very much. Thank you. It's it's hard because I don't think for lots of people, pain science is not particularly sexy. And as you say, it's doing the hard stuff. It's learning new skills. And I think if I was just to sort of think about what it is why people come to the course in the first place, when they give me their desires and wishes on courses, it's often to develop their communication skills, to develop their educational skills, to become a better teacher, because they're things that we don't do. We sort of assume we can teach people. So thanks very much. I'm glad that you both enjoyed the course, and I continue to have lots of fun and pinch myself daily going around the world teaching people. It's very nice.
We'll put a link to it in the comments, and also the other thing I'll put a link to is you and your co-author's paper in the BJSM sort of 6 months ago or so, which for me, I know it's about elite sportsmen, but I think for me it just resonates with every single patient I see in clinic. One of the best papers I read last year by a long way.
Thank you very much. That paper came from, I got asked to go and spend a few days with the International Olympic Committee in Switzerland, and there was 21, 22 of us who went there for a few days, and the Olympics really wanted to look at, how do we help people in pain, elite athletes in pain. And actually, I think you've pointed into something. We fall into a bit of a trap. We often tend to think that, chronic pain is people in wheelchairs with fibromyalgia, and acute pain is athletes. And I work with lots of elite athletes. And a while ago on a group that we had an Olympian, a gymnast, sat next to an 82-year-old lady with back pain for 45 years. And allowing those two people to talk to each other and seeing the similarities in their narratives and stories reminded me of sometimes we need to break down the barriers that we have ourselves of thinking, of categorizing people into boxes. So pain is pain, and I think acute and chronic and subacute, we have to see the similarities in terms of distress.
Yeah, we'll link to that paper below, because I think everyone should read it. I truly do. If you're taking a history, you need to read this paper. That's my take on it. Craig, anything you want to wrap up? Obviously, you just put the link to Mike's course on the video there. Yeah, just to touch on a comment that's just come in, just really quickly. I don't know if it was a joke or it was serious. From Adam Jewell, I'm fairly sure you're over analysing and overthinking this.
Yeah, I was myself.
That might be tongue in cheek. That might be someone who genuinely thinks we are wasting our time this evening. I don't know. But yeah, I don't feel like. And actually, Toby Blanford, down in Wales, who's always known for being witty, overanalyzing, overthinking. That's hilarious. I get the impression we're just scratching the surface. I think that's a beautiful comment.
There's a good metaphor to end on.
Yeah, absolutely.
Yeah.
Great.
All right. Well, thanks very much, Mike. Thanks, everyone. I'll stop the live.
Thanks, Mike.